Okay, now I have to deal with this annoying thing. Okay. Well, good morning. I hope you're all warm enough. At least doesn't show on yours. Okay. Okay, I don't have any announcements, except don't forget about the lecture quiz next Friday. It's going to be all, well, mostly multiple choice, 25 questions. Okay, so I'm going to be asking heavily. In fact, I kind of counted it up, like 5 questions on hypothalamic hormones, and I gave you 5 releasing hormones and 2 inhibiting hormones. So I'm going to ask 5 on that. 5 pituitary hormone questions. Probably 8 questions on the disorders, couple questions on negative feedback, and I think a few questions on just gland by gland. All right. So best way to prepare for that is go over the flow diagram. Go over the flow diagram. All right. Definitely. Okay. So I'm recording this. So what we're starting today, we'll probably not finish it. We might, is how the body regulates blood pressure and blood osmolarity. Not next week, that's the CPR lab. The week after that, we're going to be doing the kidney lab, and then we're going to be going over again how the body regulates blood osmolarity. Okay. So I know the last NCLEX test I looked at or asked the nurses about, some of the questions on that were about this topic. All right, like the renin, angiotensin, aldosterone system, stuff like that. So very important. All right. So regulating blood pressure is about regulating your blood volume, which is really the water content. Keep drinking tea so my throat will be a little better. How your body regulates how much water is in your blood. And your kidneys are the most important organ that does that. Now, you're writing lab report on it. You know about when blood pressure is too low, right? Baroreceptors in the aortic arch, carotid arteries sense it. They send a signal to what integrating center? The medulla, which has a cardiac and a vasomotor center. The cardiac center will increase your heart rate, which increases your blood pressure. The vasomotor center will cause your arteries to vasoconstrict. That also increases your blood pressure. And that's the opposite problem. Blood pressure is too high. Same sensor, same integrating center, but now your heart rate goes down and your arteries vasodilate. So we know this, all right? Back in chapter 1, I taught it to you, and then we just have a whole lab based on it. Well, I call that the quick fix to blood pressure. And if you remember in lab, I said when the patient, I was going to say, stands up, you want to get the heart rate and blood pressure within about 10, 15 seconds of them standing up. Because if you waited longer than that, the heart rate comes back down again and the blood pressure comes back down again. It was just a quick fix to keep you from passing out. And then the effect goes away. But there are going to be long fixes that are hormonal that affect what the kidneys are doing. And that effect can last for hours, if not days. And that's what I'm going to call the long fix to blood pressure. All right. So yes, it's more pathways. Okay. All right. So the kidneys are the most important organ to control your blood volume by how much water they retain. It stays in the bloodstream. So you reabsorb it back into your bloodstream versus how much is excreted out in your urine. That affects your blood volume. Whatever happens to your blood volume, blood pressure is going to follow directly. So if blood volume goes up, blood pressure goes up. If blood volume goes down, blood pressure goes down. All right. Okay. So we're going to talk about these hormones. Remember those flow diagrams I had you study for the first quiz? And it was based on those regulating blood pressure things. And I said, just worry about what the baroreceptors and the medulla is doing. Ignore the other half of the. Now we're going to be looking at the other half of the flow diagram. All right. So yeah, now more pathways. Okay, the quick fix is what you know. You've learned that, I think, pretty well at this point. I hope you never forget it. All right. The slow fix is going to be hormones. So has anyone heard of renin before? No, that's okay. You heard of aldosterone before. All right. I covered it when I covered the endocrine system. And do you remember what I said aldosterone causes to happen in the body, since we are having an endocrine quiz next Friday? What does aldosterone do? I covered it in the endocrine system when I talked about the adrenal cortex. It makes a little bit of estrogen, testosterone. And then there's this other hormone that comes from the adrenal cortex that's called aldosterone. And then after that, I talked about cortisol. But back to aldosterone. I said there's 4 letters in aldosterone. If you read
G-R-A.
Oh, no, I'm not asking for the hypothalamic hormone, just what aldosterone does. It's okay. Salt. Salt, because there's the letters for salt in aldosterone. All right. Causes you to retain salt. All right. If you retain salt, that means salt is going to be from your kidneys drawn back into your bloodstream. What will follow salt wherever it goes by osmosis? Water. So you reabsorb water, you retain water. And if you retain water, your blood volume goes up. Your blood pressure goes up. All right. So I'm taking something you've learned before. Now I'm going to give it to you in a new context. But we're going to start with, let's see, this is not responding. Oop, too far. Okay. You know, one of the baroreceptor reflexes, the aortic arch carotid artery baroreceptors. I'm going to teach you a new one, and it's in the heart itself. The heart itself can secrete a hormone that will regulate your blood pressure. So we're going to cover that. And then something that the hypothalamus does. All right. The supraoptic nucleus. You probably don't remember at all. It's okay. It secretes ADH. Remember me talking about it in the endocrine system? ADH is called anti-diuretic hormone. And then I asked you guys, do you know anyone who's on the water pill or a diuretic? And it makes them pee a lot. So an anti-diuretic, instead of peeing out water in your urine, you're going to retain it. And if you retain water, blood volume goes up, blood pressure goes up. So I'm going to teach you about that. And then the kidneys themselves, this renin, angiotensin, aldosterone system. So this is where I'm going with all this. Some of the stuff you've learned already. So I'm going to add some new things. And I say some of the stuff you've learned already to make you feel a little bit better. You're not having to learn all from scratch. So we know the arterial baroreceptor reflex. So this should be easy. In fact, you can look at these notes when you're writing the introduction to your lab report, or go back to chapter 1, or look at the textbook on page 5. But if blood pressure drops, let's see what my pen's doing there. All right. Like you went from a supine to a standing position really quickly, it's going to be a sympathetic response by the medulla. The neurotransmitter, got to bring blood pressure up. So the arrows are going in opposite directions. So we know, and we went over this last time, the neurotransmitter is epinephrine. We know the receptors for it in the pacemaker are beta-1 adrenergic. Ooh, I put hand lotion on my hands, and now my hand's sliding all over my screen. Makes your heart rate go up and your arteries vasoconstrict. Makes your blood pressure go up. All right. But that is going to be a short lasting effect. That'll go away after you've stood up maybe 20, 30 seconds. Your heart rate comes back down. Your blood pressure comes back down. It was just there to keep you from passing out. All right. And then the opposite scenario, the neurotransmitter is acetylcholine. Its receptor is, please, what's its receptor for acetylcholine on the heart's pacemaker? Muscarinic cholinergic. And that makes your heart rate go down. It makes your arteries open up wide. Okay. And that's what brings your blood pressure down. So you know this to death. I've gone over a zillion times, it feels. All right. So I know you'll have that. But now, here's the new thing, the long fix. And so the stimulus is going to be your blood pressure rises above normal. All right. The medulla can fix blood pressure, whether it's too high or too low. These hormonal fixes tend to be stimulated by either blood pressure's too high or blood pressure's too low. So this one, blood pressure's too high. We just finished the cardiovascular system. I said that when a lot of blood comes back to the heart, venous return, and if there's some residual high blood pressure, those chambers of the heart will stretch, right? Well, so the heart is stretched. Heart chambers are stretched. They have stretch receptors. They have baroreceptors. And when that happens, the heart secretes, I'll put the abbreviation, which stands for atrial, because it's secreted by the atrium, natriuretic peptide. That is a mouthful. That's why I like the acronyms, ANP. Okay, so here it is right here. Now see, and then it's saying going to the kidneys. I'm going to cover this. Yes, it can also cause your arteries to vasodilate, but I'm going to talk about what the kidneys do. Okay. So, and you guys have this version of the PowerPoint? Is this one you have? Good. Okay. ANP does this at the kidneys. All right. It will increase filtration rate. That will decrease salt and water retention. So you're going to have increased urine output. You're peeing more. If you're peeing more, you're losing body water. And because you're losing body water, your blood volume goes down. The effect, if the blood volume goes down, is you have decreased blood pressure. So keep in your mind, what the kidneys are doing are going to have a long-term effect. So that will drop blood pressure for hours, if not days. As long as that ANP is in your bloodstream, that's your body's way of trying to regulate that blood pressure. People who have chronic high blood pressure, yeah, their body is doing this. I imagine if you measured their ANP levels in their bloods, I bet it would be screaming high. But when the body can no longer fix blood pressure through a pathway like this, that's when medicine starts in, and people take pharmaceutical agents to help treat their blood pressure, right? So only is secreted when blood pressure is too high. Its goal is to bring it back down. And here's what it's doing. So it's another pathway. Okay. Does that seem straightforward? Keep in your mind what is happening to whether your kidneys are retaining water, water's going back into your bloodstream, blood volume's going up, blood pressure is going up. If the kidneys are peeing out body water, you're losing body water, blood volume, blood pressure come down. So that's going to be the common theme. Okay. All right. Everyone get a chance to write that down? It wasn't a lot of writing. Okay, now, when we do the kidney lab, when we come to that, your hypothalamus regulates so many things. One of the things it regulates is your blood osmolarity. You might hear in the nursing program, they might call it blood osmolality. It's simply a vocabulary difference. It's basically your body's salt content. And it's not just like sodium chloride, but it's other salts as well. So if your blood osmolarity rises, so it has a set point, 280 to 290, some textbooks will say 285 to 295, semantics, it's not a problem. Let's say if the blood osmolarity rose, and that can happen if you are not drinking enough, not staying hydrated, or you just ate something or drank something really salty, your blood salt content's going to go up. Hypothalamus is going to, it's the sensor, integrating center, and effector. All right. It's going to do the following. So it releases ADH, which I'll define over here, anti-diuretic hormone. And see what I've got here? Secreting ADH, it's going down to your kidney nephrons, your kidneys. So it's a hormone secreted only when your blood salt content is too high. ADH is not secreted if blood pressure is out of whack. It won't be secreted if blood pressure is too low or blood pressure is too high. Its main goal is to change your blood salt content. It will affect your blood pressure, but that wasn't the goal of ADH. And I want to make that clarification because on some future exam, I'm going to ask you which of these hormones can fix blood osmolarity when it's too high. And I'll have some hormones that affect blood pressure, surely, and then I'll have ADH. All right. Or I could ask you a blood pressure problem. All right. What hormones secrete when blood pressure is too high or too low? If the answer is not going to be ADH. Okay. So some future exam, I guess the last exam, that's kind of crazy because its only goal is to fix blood osmolarity. So here's what ADH causes to happen. So you will increase water reabsorption at the kidneys. You're retaining water. So in other words, go back to normal. I don't know why I thought I was trying to expand the screen. Weird little computer things. You retain water. So if you're retaining water, it's going back into your bloodstream. That will make your blood volume and blood pressure go up. But that's not the end of the pathway. That wasn't the goal of the hormone. The goal of the hormone was to increase the amount of water that's in your bloodstream to dilute the salt that's there. And so if you put water back in the bloodstream, your blood osmolarity goes down. That was the goal. All right. And the opposite. So when we have that kidney lab, half the class is going to just drink water, half the class is going to drink a salt solution. So and it's not a dangerous amount of salt solution. It's no different than having a piece of pizza or something like that. All right. But it will be enough that 30 minutes later, after that salt is going into your bloodstream, your hypothalamus will sense it, your blood osmolarity went up, and it's going to release ADH. 30 minutes after that, you're going to see in those people, their urine output goes down. So here's something that happens. Increase water reabsorption, decrease urine output. And I'll put that because that's one of the things you're going to be measuring in the kidney lab. You can measure how much you pee. All right. Now, opposite scenario for the people that drink, if you just drink a bunch of water, maybe even as much as this, maybe more than that, okay? You're going to dilute the salts in your blood. Hypothalamus senses that too, and it will inhibit ADH release. And without ADH, you'll have decreased water reabsorption at the kidneys. You will increase urine output. You're losing body water. So that makes your blood volume and blood pressure go down, but that wasn't the goal of inhibiting the ADH. The goal was to increase your blood osmolarity by diluting it with the water you retained. So how's that for a pathway? Does that make sense? Okay, this is another one of those big topics where you're like, oh God, more pathways. So when you're studying this, go back, and I have under the cardiovascular chapter links to, if blood pressure is too high, use this flow diagram. If it's too low, use this flow diagram. And then I have if blood osmolarity is too high, and I have the flow diagram for that. Okay. Now, there's a disorder of ADH secretion. When the hypothalamus doesn't secrete enough of it, you got a problem. I'm sure there's synthetic ADH you can take, but diabetes insipidus. Don't get it confused with diabetes mellitus or mellitus, however you pronounce it, which is your diabetes. All right. This is a disorder of not enough ADH. So when I think of diabetes insipidus, I think of you are always sipping on water because you're dehydrated. Because without ADH, you're not going to be retaining water, all right? You have decreased water reabsorption at the kidneys. You're peeing out body water right here. If you're peeing out body water, your blood volume and blood pressure go down. And this is a chronic condition, okay? So this is one of the cases where chronic low blood pressure could be due to a hormone problem like this. So you're always dehydrated, so you're always sipping on water. So that's how I remember that one. All right. I don't know how common it is. Has anyone ever heard of it before? Because you have. Oh. That is a lot. You can actually dilute the salts in your blood to such an extent that you have heart problems. You can actually overdo it. Well, each person's physiology is going to be a little different, okay? But it is possible. Google it. You're WebMD. Can you overhydrate yourself? You absolutely can. Some people, it's a pathology, like an OCD thing, all right? Water drinking. Bless you. Need tissues? Okay. Yeah, so be careful about that. I mean, but they say drink a couple quarts of water a day. That's fine. A gallon, it depends on the person. All right. If it's like someone who's just like 100 pounds, a gallon of water a day might be a little bit much for your body mass. All right. So it just depends. It just depends. But yes, you can actually overdo it. That is a fact. So good. I'm glad you raised your hand. Okay. So now the long pathway of all the pathways I've taught you. This is the longest one, but this is the one that there were NCLEX questions. Anyone knows? Do you guys know what the NCLEX is? Once you go through your nursing program, get your Bachelor of Science in Nursing, right? Then, but you're not ready to practice as a nurse yet. You have to take a licensing exam, and that's the NCLEX. All right. So yeah, I took something similar to it as a vet tech. Damn. The test was like the test was like 3 hours long. And then I had to do a practical, which lasted all day. So anyway, but yeah, they want to make sure that you're not going to go out there and kill people. So they want to test you. All right, but the renin, angiotensin, aldosterone system was on the NCLEX, so I would know it. I don't know what the new NCLEX is going to ask. They don't even really know it very well. Remember when Dory Weaver came in and said they changed the NCLEX, but I still say this is a good pathway to know. So the stimulus is going to be low blood pressure. Okay. High blood pressure, the hormone fix would be the ANP coming from the heart. So this is a hormone fix when it's low blood pressure, and it's low blood pressure going into the kidneys. The kidneys themselves are going to secrete something to fix that blood pressure. So if you've got renal artery, the blood pressure is too low. And remember from lab, the blood pressure normal range, and specifically it's arterial blood pressure, because only arteries carry blood under pressure, right? We know that from anatomy. Do you remember it from lab? I think I had a question on the quiz. 80 to 160 millimeters of mercury. Okay. And if you look at a different textbook, they may say something that's slightly different, but again, it's just semantics. But that is the normal range. If blood pressure drops below that, like this case right here, if it's below 80, this system will kick on. If it's above this, your heart will release ANP. Those are hormonal fixes. And then the medulla can always do its thing too. It doesn't last very long. So the sensor, integrating center, and effector here are the kidneys themselves. And I think you probably learned this in anatomy, the juxtaglomerular apparatus. And since that's a mouthful, I just call it the JGA. Are we good with that? It's this thing attached basically to your nephrons. It is going to secrete a hormone. I'll get to that in a second. And ultimately, that hormone will cause an increase in your blood pressure. It's going to do it by increasing water retention. It's going to do that by increasing salt retention first. And what was the hormone we were just talking about that causes you to retain salt? Aldosterone. Thus, the renin, angiotensin, aldosterone system. I'm sorry about, I forget that's in the way. Let's move it like that. All right. So, but first, this thing is going to secrete that. And then it's going to involve various forms of that. And then you get to the aldosterone. And then you get to the fix in the blood pressure. Okay. So I realized when I posted this, I forgot to take away these boxes and things like that. So you just have these boxes in your notes. When I do the completed notes, those boxes will be gone. I just didn't think about it. So the drop in blood pressure is sensed by the JGA, and then it is going to secrete renin. All right, so we have, oops, not doing it. Not responding to me. Okay. So renin right here, coming from the juxtaglomerular apparatus. Renin is now in the bloodstream. It's going to go to the liver. So the liver is yet doing something else. All right. The liver, with that stimulation, will change basically angiotensinogen here into angiotensin 1 here. All right. So renin causes the liver to convert this to angiotensin 1. And then the angiotensin 1 is in the bloodstream. It's going to go to the lungs, of all places. It's a long pathway. The lungs have ACE, which stands for angiotensin converting enzyme. And I'll have it on the next slide. So the lungs basically take the angiotensin 1 that was in the blood and they convert it to angiotensin 2. All right, because of that enzyme in the lungs. Angiotensin 2 stimulates the adrenal cortex to make aldosterone. So now we're tying into that endocrine lecture. And if you look at it, aldosterone, it's got the letters A, L, and S, and T, which spells salt. That's not why the hormone's called that, but it's one of those weird things I associated with the hormone to remember it. Aldosterone increases salt retention. So go back. So come here, pen. You retain salt in your blood. And told you that lotion's making everything slick. God. So with the salt retention, waterfall of salt back into your blood. All right. So then I have this little thing here. This is your kidney nephron, and I'll have it run again. Let's see, do it one more time. Okay, so here is going to be, one of these is going to be salt. So as I said, the red thing was, yes, the red thing was salt. And when the salt goes back into your bloodstream, the water comes out of your nephrons into your bloodstream as well. So when you increase your blood volume, all right, that's going to increase your blood pressure. So the kidneys, under the influence of aldosterone, put salt back in your bloodstream, water follows salt back into your bloodstream, blood volume, blood pressure go up. So this is by far the longest pathway. There'll be no pathway in this class longer than this. That's it. All right. So sigh of relief, maybe. All right. Not the most interesting thing to cover on a Friday afternoon, but knowing that it could be on the NCLEX, maybe that will be more important. If your blood volume and blood pressure are too high, you won't have renin release. Okay. Now, let me say something while I'm on this slide. So all of these fixes, let's say blood pressure is too low, right? Multiple things are happening at the same time in your body. Yes, if your blood pressure is low, your arterial baroreceptors do sense that. They send a signal to the medulla. The medulla tries to fix it by increasing your heart rate, clamping down on your arteries to make your blood pressure go up. But since that effect doesn't last very long, this is also happening simultaneously. The renin's being released, you get aldosterone. Aldosterone is changing what your kidneys do, and that effect can last for hours or days. All right. Okay. So, anyone know someone who's on ACE inhibitors? Have you ever heard of it? There are lots of ways to fix blood pressure problems. Okay. So, ACE, all right, angiotensin converting enzyme found in the lungs. Okay. ACE inhibitors are medications for high blood pressure. Think about this. Remembering that once we have, after renin, we get angiotensin 1, and the lungs convert angiotensin 1 to angiotensin 2 by ACE, that enzyme. If you inhibit that enzyme, this can't happen. You won't get angiotensin 2, which means you won't have aldosterone being produced, which means you won't retain salt and water in your blood. You're going to pee out salt. Water's going to follow that salt out in your urine. And if you're peeing out body water, blood volume goes down, blood pressure goes down. So now we know yet another drug that can fix blood pressure problems. Okay. We've talked about beta blockers. We've talked about sodium and calcium channel blockers and lots of other things. Here is another way to have blood pressure addressed, another drug. And why do we have so many different ways of coming at the same problem? What happens if the beta blockers don't work on one patient? They're not responding and their blood pressure is still sky high. Okay, well, maybe we'll try sodium or calcium channel blockers. Oh, unfortunately, that's not working either. Okay, we've got ACE inhibitors up our sleeve. We can try that. All right. So it's a very, very common drug prescribed for high blood pressure. Yes.
Would this be more of a long-term fix?
Yes. Yes. I literally call the hormonal fixes to blood pressure a long fix. Because that hormone can, once it's released, can be in your blood for hours, if not days. And that's why I call them literally the long fix, as opposed to what the medulla is doing, which is just a quick fix, like a temporary fix, like a Band-Aid. All right. Okay. So I hope I made that at least applicable to nursing, because it is a very commonly prescribed drug. I'm surprised no one here has heard of ACE inhibitors. Usually, I know you've heard of beta blockers when I first introduced it, but anyway. So I do have a clinical app. Let's see if its link is active here. There we go. All right. Here's another thing too, and I'll add it. Oh, where are you going? Staple it. Okay. Angiotensin converting enzyme inhibitors, ACE inhibitors, to control hypertension. These drugs block the formation of angiotensin 2, and they lower blood pressure by 2 mechanisms. One, I just taught you. You won't have aldosterone secretion without angiotensin 2. But angiotensin 2 itself affects, basically, it causes vasoconstriction of your arteries. And I'll go back and I'll add that. So the reduced stimulation of aldosterone secretion. So you're not you are retaining salt and water, and there lowers the blood volume and blood pressure. But this hormone itself coming out of the lungs can make your arteries vasoconstrict. So let me go back and add that, because that's a good thing to include. There we go. There we go. Okay, so let me add that right here. Angiotensin 2 can cause, give myself some space here, artery vasoconstriction. All right, that can do that by itself. But then with aldosterone secretion as well, that definitely will jack up your blood pressure by changing your salt and water reabsorption. Okay, so remember ACE inhibitors. No, so angiotensin 2, and since it's in the reading, the link, I want to include it, be consistent. Angiotensin 2 by itself, just coming out from the lungs, getting into your bloodstream, can cause your arteries to vasoconstrict, and when that happens, your blood pressure can go up. But angiotensin 2 then continues down to your adrenal cortex, stimulates aldosterone secretion, and the aldosterone makes you retain salt and water, which will increase your blood pressure. Yep. So a couple different things are happening. Okay. I'm glad you asked, because if it wasn't clear for you, it might not have been clear for someone else. Okay. So since we're talking about aldosterone again, and since we have an endocrine quiz next week where I might be asking stuff about this, okay, because it is an endocrine disorder. If you have Addison's disease, you have low aldosterone. So I remember the A in Addison's has to do with aldosterone. So your adrenal cortex is not pumping out enough aldosterone. So it's not really responding to renin like it should. Okay. So if you don't have enough aldosterone, you have decreased salt reabsorption. You'll pee out salt. If you're peeing out salt, guess what's going to follow that salt out in your urine? Water. So you'll have increased urine output. Okay. So if you're peeing out salt, you're losing salt. And that's called see, it's got literally the symbol for salt in it, right? Hyponatremia is low blood salt. So if you are losing salt, it's a funny thing. Wherever salt goes, potassium seems to go in the opposite direction in the body. I don't know why, but you'll retain potassium, and the symbol for potassium is K. So you have high blood potassium. Do you remember a danger of having high blood potassium? It can slow your heart rate down. Yep. Because potassium is the ion channel that slows your heart rate down. So yes. So someone has this disorder, they're going to have interesting symptoms. And as their future nurse, right, you're going to be on the lookout for these things, right? One of the things you normally do is measure their blood pressure and their heart rate and stuff like that. And you might see this person has really low heart rate. They'll have bradycardia, which means slow heart rate. Okay. Polyuria. That's going to be one of the vocab questions on your kidney lab handout. Usually poly means much or many, and urea means urine. So you have increased urine output. These people are peeing a lot because they're not retaining salt. It's going out in the urine and water's following it. Hypovolemia is low blood volume. And your blood volume is low because you're losing body water in pee. And because your blood volume is low, your blood pressure is low. So I'll just put low BP. And also the skin bronzing thing, and I never really have looked up the physiology of why that happens, but sometimes people will be, well, I'm not usually this color. I don't know, my skin started getting darker and darker recently. It's the Addison's, right? Okay. Now the opposite problem is Conn syndrome, and I think I covered that in the endocrine system. I think I did. Can't remember right now. But it's also called hyperaldosteronism. Addison's might be called hypoaldosteronism. It depends on how you learn it in nursing school. So now the problem is you have excess aldosterone. So you're retaining now salt. So you have hypernatremia. You have high blood salt. Okay. You're retaining it instead of losing it out in your urine. If you're retaining salt, you tend to pee out potassium. So you have low blood. I'll just put K. Low blood potassium. Now, oliguria, oli, the prefix means small. And so that means low urine output. They're not peeing as much because they're retaining all of that water because they're retaining salt. If they're retaining water, you have high blood volume. All right, so put here, you retain water. And if your blood volume is high, you'll have high blood pressure. And the reason I have this picture of adrenal gland here is this is apparently a normal size adrenal gland. And this one's thickened, all right? That could indicate an adrenal gland tumor, which they're common enough. Actually, they are. And a tumor does not necessarily mean cancer, it just means abnormal growth. And so if you have adrenal hyperplasia or tumor of the adrenal glands, you could have either of these problems. It simply messes up the adrenal gland, and so it can't produce the hormones or produces too much of them as you would normally see. Okay, how we doing? That was a lot to throw at you today. All right, 1, 2, 3 new pathways. Okay. Okay, so I believe these links are working. I think I checked them before coming to class. All right. So we have now this low blood pressure flow diagram. Let's hope it comes up. I'll give it a second here. Nope, click it again. Okay. All right. So now you're going to need to know both of them. Before you just memorize this pathway. But now you're going to know the JGA secretes renin if blood pressure is too low. And then the liver converts angiotensinogen to angiotensin 1. Then it goes to the lung, which has ACE, converts angiotensin 1 to angiotensin 2. And then angiotensin 2 goes down to the adrenal gland and it pumps out aldosterone, which will increase salt reabsorption, then water reabsorption, and it will increase your blood volume and blood pressure. So we covered that. That's the renin angiotensin aldosterone system. Okay, let's get back to the PowerPoint. Where did you go? Okay. And then the high blood pressure fix. It's going to look like this. And I'm actually going to end with this stuff today because it's so much thrown at you. We learned this pathway, the medulla and everything. Now we know the heart baroreceptors. It gets stretched with blood pressure coming in high. The heart secretes ANP, and that goes down to the kidneys and causes you to decrease water reabsorption. It increases your filtration rate, but basically you're going to pee out body water. And if you lose body water, your blood volume and blood pressure come down. All right. So that was the ANP response. Okay. And then for the osmolarity, basically you really need just to study this one. Okay. If you have too high salt content of your blood, your hypothalamus senses it, secretes ADH. ADH goes down to your kidneys, which you will retain water. Your urine output goes down. Because you're retaining water, your blood volume and blood pressure do go up, but that wasn't the goal. Because you're retaining water, it dilutes the salts in your blood and makes your osmolarity go down. All right. Okay. And then if that weren't enough, I have this as well, because that's a flow diagram. You can practice filling it out because that is the best way to memorize this stuff is practice filling it out. I also just have it written down. So I just have a PDF where if blood pressure is too low, your baroreceptors and medulla will respond with the quick fix. And then the long fix is renin secretion. If blood pressure is too high, your medulla takes a shot at fixing that too, but that's the quick fix. Your heart can release the ANP. You pee out a bunch of body water, bring your blood pressure down. And then if your blood osmolarity is too high, that is the stimulus for ADH secretion. All right. I'm going to let you go. Because that's enough information for one day. All right. I'll see you guys on Monday. You too.
Friday is only.
Yes. Yes. Mhm.